For those who are watching the recording, we are so excited to have Dr. David Goodwin, one of the best physicians in our region, on this call to talk to you a little bit about new approaches to the athletic hip and about his own practice and background. So without further ado, Dr. Goodwin, the floor is yours.
Thank you. First of all, thank you for the opportunity to talk to you all tonight. This is a topic that's near and dear to my heart as a sports medicine specialist. But first of all, thank you to everything that you all do. Physical therapy is the most utilized part of my practice. Even though I'm a surgeon, I depend on physical therapists before surgery, after surgery. And to be honest with you, most of my day is telling people they don't need surgery. They need physical therapy. They need to relearn how to use their bodies and activate muscle groups they've neglected. So it makes a big difference when I realize they're getting their care to a place that like Jackson Clinics, where they're getting the best care possible. And it's really become independent of location. I routinely see people who have issues that shouldn't need surgery, partial thickness cuff tears, gluteal issues, and then a lot of things we'll talk about tonight. And it's very clear which ones get better with physical therapy and where they're doing their therapy. So it's just an honor to be able to talk to all of you who have helped me and my patients for many years up to this point and will, I know, into the future. So anyways, what we're going to talk about tonight is a lot of stuff around the hip, not arthritis. There's really only one treatment modality for that, involving metal and plastic in the most severe of cases. But I'm going to talk more about my practice, which is fairly unique, and then about a lot of the things I've learned in treating hip issues and those things around the hip, and more importantly, how we can all continue to work together. So, like Ben mentioned, my name is David Goodwin. I'm a sports medicine specialist with arthritis and sports orthopedics in Loudoun County. What we're going to talk about tonight in regards to the hip is the anatomy and biomechanics. We're going to talk about why the hip hurts, as well as the diagnosis and non-operative management of several conditions in and around the hip. And then we'll talk about the big shift, new technologies, new techniques, things that have changed the way I practice medicine, and things I wasn't doing 5 years ago. But part of the fun in being an orthopedic surgeon is constantly learning what's new and adapting because it's what helps our patients do better. Then we'll talk about the applications of these advances. And finally, we'll educate ourselves so we can educate our patients. Because every time I've given a talk like this on something new or something that's more cutting edge, we find more and more people who can benefit from less and less invasive approaches, or finding that shifting the paradigm from one modality to another is really what our patients need. So it's a lot of information to cover tonight. I don't think it's going to take an entire hour. We'll leave some time for questions afterwards, but I'll leave my contact information on the last page, which brings me to my last point. I love getting texts and phone calls from my physical therapist. Whenever there's a question about a patient, a post-operative protocol, or just a concern, these are my favorite phone calls to get because you all are in the trenches so much more than I am and see these patients so much more than I do. I see them at their worst, sometimes at their best, but it's all those times in between that really shift how they do. So the last slide, I'll throw my contact information on there, and please use it. Call, email, text, anytime. I don't mind. All right, so a little bit about me. I'm a board certified orthopedic surgeon. I'm fellowship trained in sports medicine. I did practically all my training in Washington, D.C., where I went to college and medical school at GW, then went down the street or up the street, depending on the location, to Georgetown University for a 5-year orthopedic surgery residency. And then I decided Georgetown, I wanted to work with athletes. I wanted to work with active people, and I wanted to do really challenging arthroscopic procedures. So that brought me to NYU Hospital for Joint Diseases, where I did a fellowship in sports medicine. And it seems like every fellowship in sports medicine has a slightly different focus. I didn't work with any professional athletes outside of a professional ballet company. They had the New York Rangers at one point, but not when I was there. But what I was able to do was work at a world-renowned hospital that's 14 floors and nothing but orthopedic surgery. And everything I've seen that goes on there is 5 years ahead of the rest of the country. So staying in contact with my attendings and peers from there, I feel like keeps me ahead. A lot of my fellowship was in hip arthroscopy as well as cartilage restoration and transplantation, and then a lot of pediatric sports as well. So we'll hit on some of the things I learned on there, but a lot of the stuff we're going to talk about tonight is things I've learned on my own. So this is where you can find me now. I'm with Arthritis and Sports Orthopedics. I've been there for almost 10 years. It's my first job out of training. I love it here. Great work environment, great peers, and I think the best doctors I've ever worked with. So we have offices in both South Riding, Virginia and Sterling, but we see patients from all over the DMV. I've seen patients routinely from West Virginia, North Carolina, and sometimes those are for some of the things we're going to talk about in our discussion tonight. But really, one of the things that drew me to this practice is when you do a sports medicine fellowship, that's what you want to be doing in your career. I didn't want to be doing joint replacement. I didn't want to be doing carpal tunnels or fracture care here and there. I really wanted to do what I'm passionate at and what I feel I get better at every year. And that's something that's more unique to our practice, where we are all fellowship trained and really stay within our subspecialty. On the side, I've also become an adjunct clinical professor of medicine at George Washington University, my alma mater, and this has been an honor working with medical students for the last 6 or 7 years. They spend time with me in their preclinical years when they're otherwise not exposed to any clinical medicine, and they'll spend half days or full days with me in clinic and sometimes in the operating room. And I had the honor just 2 weeks ago of giving a keynote address on campus for their second look day. So it was unbelievably weird being back on campus. I graduated medical school 16 years ago. So it was a really nice opportunity to go back there and continue to give back to the university that believed in me so many years ago. So, anyways, here is what I do more specifically in the office. In the office, I see everything. I love everything orthopedic: neck pain, shoulder pain, foot pain, hand pain, ankle pain. I'm the first line of defense for a lot of people. When I first started in Loudoun County in South Riding, there were no other full-time orthopedic surgeons out there, and I feel like I became the small town doc. I would take care of people for their shoulder injuries and then their kids for their wrist fractures, and I loved every bit of it. But then as things get more complicated, that's where we kind of draw on our peers. So when things need a next level of care, they need epidural spinal injections, they need a joint replacement, that's where I bow out and refer to my partners, not just in my practice, but the better people I know in Northern Virginia and the DC area too. So when it comes to surgery, I stick with what I'm passionate at, what I do, and I tell my patients I really only do 3 surgeries: iScopes, knees, shoulders, and hips. And sometimes that involves a rotator cuff repair. Sometimes it involves doing cartilage transplants, although those are usually done open. And then times like today, I did bone grafting for a failed ACL on a girl who's already had 3 prior knee surgeries and needs to basically start over from the beginning, have her tunnels plugged, and start from there. So this picture on the top right, that is one of the first cases I did in practice. That's an allograft ACL. The allografts always look shinier and nicer for some reason. I think it's the irradiation. And then on the bottom right is an osteochondral allograft transplant. So this is an entire femoral condyle in a 25-year-old who had a traumatic injury, lost a huge amount of cartilage and bone. And through a one-stage procedure, she got fresh allograft from a cadaver with viable cartilage cells and about a 90 to 95% 10-year survival rate on this procedure. So these are the few things that I do routinely, but they're things I'm really passionate about and have continued to change with my practice as I've grown, as the technology's grown. So now we'll focus more on the hip, which makes about a third of my practice, the other third being knees and shoulders. And more specifically, when I think about the hip, it's really a complex structure. When people say hip pain, most of the time they mean lumbar pain. It's coming from the SI joint, the lower lumbar spine. But when I think more specifically about the hip joint itself, there's 4 regions. There's the lateral side, the trochanteric region. There's interarticularly, where there's cartilage and some of the other places we'll talk about. There's posterior, and then there's anterior. And there is a ton of overlap between these structures. What I tell people in terms of the hip is it's not like a finger. If you say my finger hurts here on the edge of the finger, that's where the pathology is. The hip is so much more complicated, and it makes it even more important to actually listen to your patients and examine them and not just read MRIs, because everybody has an abnormal MRI over the age of 40. But the difficult thing is identifying what's the pain generator and how do we address it. So starting with the lateral hip, which used to be the bane of my existence, it's the bane of my partner's existence, but this has become such a huge part of my practice that I love seeing lateral hip pain. The way to think about the lateral hip is to compartmentalize, and I feel like when you simplify things, it makes it a lot easier to follow. So the lateral hip, there's only 3 layers. There's the IT band, there's the trochanteric bursa, and then deeper below is the glute medius and minimus. And these are areas where oftentimes there can be referred pain from the lumbar spine, the SI joint, even intra-articularly. But the bottom line is if you press on that spot and it hurts and they say that's the pain I get every day, one of these 3 is the problem. So it's a source of local nociception in the soft tissue. It's related to lateral hip pain, and it's a big generator of pain in really two different age groups. We see it in a lot of females in their 60s and 70s, and then also see it in the early 40s for whatever reason. Intra-articularly, there's really only three structures. There's cartilage, there's labrum, and there's more cartilage. And then there's bone. So I guess there's four there. And these really play on each other. It gets a little bit tougher to explain the source of pain when we start getting into the types of labral tears because a labral tear in an 18-year-old that's symptomatic is very different than a degenerative labral tear in a 75-year-old. And it's not always clear on the MRI. A lot of times these MRI reports will say labral tear or chondromalacia. And then depending on the age, the images, it's that saying that the picture is worth 1,000 words. In the hip, it's worth more than that because a degenerative labral tear where it's frayed and the result of arthritis or impingement is very, very different than the acute traumatic labral tear that we sometimes see in teenagers. Next, we'll get to the posterior hip. Here we have the hamstrings arising from the ischial tuberosity and an area called the ischiofemoral space. A growing trend in orthopedic surgery, a growing area of concern is impingements, and not just femoral acetabular impingement, but anterior, posterior, and even lateral side impingement, which is extremely rare. This is something I just wrote a review article about extra-articular hip arthroscopy, and basically how to address these impingements around the hip. And just from writing and continuing to contribute to the literature, I've learned a lot more about these rare sources of pain and how to screen our patients for it. So then the other area outside of the hip joints is anterior to the joint itself. Here, two main sources of pain, the iliopsoas, the giant hip flexor, which inserts on the lesser trochanter, and then the pubic symphysis, which around 2005, 2010 started to gain a lot of steam in the descriptions of athletic hernia or pubalgia. And we'll talk a little bit about that at the end. That's an issue that's continuing to basically change in its diagnosis and treatment. And that part's interesting in that as orthopedic surgeons, we diagnose it, we see it, but we don't treat it. That really relies on physical therapy, more physical therapy. And then in the very, very rare case that goes on needs surgery, this is a general surgeon procedure. So in 10 years, I've only had one patient I've referred for surgery for that issue to give you an idea how rare it is. And it's even rarer to find a general surgeon who has expertise with this type of procedure because it's not a typical hernia operation. So next, we're going to talk about the hip pain by region, starting with my favorite, or second favorite. I like labral tears the most, but greater trochanteric pain syndrome is lateral side of hip pain. It's often tender along the greater troch, and a lot of times, especially in our older patients, there's coexisting lumbar pathology. Here, it's exceedingly important to differentiate the two. So every time I see a patient with hip pain, they get examination of the lumbar spine and the hip. I'm pressing and poking all over their hip, their lower back, their buttocks, basically trying to identify where is the pain coming from. And unless they say when I press the outer side of the hip, that's the pain I get every day with walking, you got to assume it's somewhere else. And a lot of times there's coexisting pathology where then you have to figure out which one's the bigger problem. And that problem changes week by week. And this is again where I rely on my physical therapy partners to tell me, look, what you might have thought started as a greater trochanteric pain syndrome, it's all in his back now. We really need to focus on the back. So the interesting thing that I've learned about greater trochanteric pain syndrome, especially in the last 5 years, it's not a bursitis. For decades in orthopedic surgery, we've said it's just a bursitis, give it a cortisone shot, and you'll be fine. But that could not be farther from the truth. There have been a number of ultrasound studies just since 2021 that have shown the bursitis is really only present in about 10% of hips, but more than 80% show evidence of gluteal tendinopathy, primarily affecting the glute medius, but also the minimus. So what this has taught me is it's more important to address the tendinopathy. And this is also why a lot of our patients with greater trochanteric pain syndrome respond better to physical therapy. If it were just a bursitis, a sac of inflammation in that area, cortisone should cure it. But when it's a tendinous issue, that something needs to be loaded, it needs to be strengthened, and needs really to be rehabbed appropriately. So again, this is where I depend on a history and examination. I only get MRIs in these patients if I'm concerned for an abductor tear. I think MRIs are 100% overutilized in our healthcare system. And when patients ask me for an MRI, I basically educate them. The only reasons I get an MRI is if I'm planning surgery or planning an epidural spinal injection from a physiatrist or pain medicine specialist. Diagnosis should really be made based from the patient's history and examination, or in cases where there's just not a lot making sense in my mind, I can't figure out the diagnosis, then it's a real help. But I rarely get MRIs of the shoulder or hip unless we failed non-operative management, cortisone injections, lots of therapy. To me, I don't really use an MRI to confirm a diagnosis because then it's a waste of time and money if it's not going to change your treatment plan anyway. So for Gerd trochanteric
David,
pain syndrome, yes.
I'm not sure if you saw the comment come through, but John said preach in all caps.
No, I can't see the comments, but I appreciate that. Just interrupt me as we go. I can talk about this stuff all day. So I feel like that's the easy way out. You get an MRI, you get your diagnosis, but you also get 14 things you don't need to know. And my big problem with it is if it's not going to change your treatment plan, so what? So the only cases of Grade trochanteric pain syndrome where I get an MRI is where there's a Trendelenburg Gates or there have been many cortisone injections. All things that make me wonder, is the tendon weak or is there going to be an issue in terms of the quality? And that brings to my next point that I think you all are going to enjoy as well is that cortisone is poison. It's really toxic throughout the body. I'll do cortisone injections once, maybe twice for rotator cuff issue, for knee osteoarthritis, for gluteal tendinopathy. But cortisone kills cartilage cells. It tears tendons. It's not curative in a lot of people. So where a lot of this is coming from is the first set of second opinions I started seeing on Grade trochanteric pain syndrome, where people have had almost double-digit injections in their hips of cortisone. And this is one such case. So cortisone weakening a tendon. This is a T2 axial that shows a full thickness tear of the glute medius tendon, where that large white area is. And so my thinking with this is if the second or third injection hasn't worked, the fourth definitely is not going to, and you're going to create more problems. A partial tendinopathy or partial tendon tear is so different than a full thickness tear that's almost like the rotator cuff of the hip. So the other thing that has really evolved in my practice is the use of platelet-rich plasma. This is different in that versus steroids, we're seeing much better longer-term outcomes and not just localized to Grade trochanteric pain syndrome. This is one study that looked at PRP versus steroids for a GTPS and found significantly better outcomes and longer-term relief with PRP injections. So for those of you who don't know, platelet-rich plasma, it's a treatment option that involves concentrating platelets from a patient's own blood and then injecting that concentrated plasma into an injured or damaged area to stimulate healing. It's a type of regenerative medicine that aims to accelerate tissue repair by using your body's own natural healing mechanism. When we do in the office, it's about a 15-minute process. I draw about 15 cc's of blood from the arms, spin in a machine for 5 minutes, and then we inject the yellow part back in. That yellow part doesn't actually cure anything. It's a messenger pathway. So the yellow part, the lighter part, is the platelets in the plasma, and it contains these growth factors, VEGF, TGF beta 1, a lot of different messenger pathways that basically drive the inflammation out of that area. And I've seen the most incredible results with PRP for things that we used to assume would need surgery. The highest success rates I'm seeing with this, we'll run through in a minute. Knee osteoarthritis, labral tears in the shoulder, partial thickness cuff tears, people that have gotten better with cortisone, but not the long-term relief they're looking for. With PRP, we're seeing much longer-term results, in some cases even permanent. So PRP I use all over the body for arthritis, knee, shoulder, ankle. I've even done it in the first metatarsal phalangeal joints. I use it for tendinitis and lateral epicondylitis, the rotator cuff, the Achilles. And then there's a big debate about leukocyte rich versus leukocyte poor, meaning are there a lot of white blood cells or are there not? The theory is that you want less white blood cells in an inflamed environment such as osteoarthritis. But the reality is the clinical studies show no difference. For instance, osteoarthritis, lots of white blood cells. You want that PRP that doesn't have much white blood cells in it, which happens to be the smaller blood draw and the shorter procedure. Leukocyte rich, to give you an idea, requires about 60 milliliters of blood, it's about 4 times the amount, and has to spin for about 45 minutes to an hour. It's also anywhere from 4 to 10 times more expensive, depending on the practice location and the pricing model for it. So this is one where leukocyte poor white blood or leukocyte poor platelet-rich plasma has actually shown equivalent outcomes to bone marrow at this point for a lot of different applications. So this has become my go-to for a lot of different issues around the body. And the reason is because there's data that shows it works. It's not just anecdotal. There's a ton of literature out there that shows it's better than cortisone, it's better than viscosupplementation, and it works for so many issues, including frozen shoulders, plantar fasciitis, and a lot of others. So the recovery from PRP, the day of the injection, there's some soreness. I tell people usually they start to get better about 10 to 14 days later, and then it continues to improve from about week 2 to week 10. I see people back a month after the shot, and we very rarely need to do more than one injection. Most of the clinical studies on PRP are based off of 3 injections spaced 1 to 2 weeks apart, but in my experience, it's really one injection that works or it doesn't. And sometimes it's a nice adjunct of viscosupplementation, but the bottom line is it's become such a reproducible tool to heal my patients that it's become our second or third line treatment when cortisone, physical therapy, and other modalities don't work. So I also use it with surgery. It's been shown with rotator cuff tears to increase healing rates and medium large tears. This is by modulating inflammation, improving healing on a microscopic layer. So I use it at the time of rotator cuff repairs where I inject it right into the tendon at the end of the procedure. I use it with hip arthroscopy. I use it for a lot of applications around the shoulder, even including labral tears, such as slap tears, where there's a non-inconsequential risk of it not healing. In some of these settings, there's no proven benefits, but also no proven harm. I see John has a question.
Yeah, thanks, Dr. Goodwin. Appreciate the information. And yeah, I was the guy who said preach earlier, so I could listen to you talk all day. Do you find any difference in how you're using PRP based on tissue quality? So in other words, relatively young, relatively healthy, relatively active versus maybe older and sedentary.
So that's a good question. I think the results show that the concentration of platelets and those growth factors are better in younger people. So I see a better healing response in younger people. What I've learned from this is it's not the shot alone that does it, except in osteoarthritis. In a tendinous issue, you still need the physical therapy. You still need to load the tendon. So I think there's a better success rate in younger people, but at the same time, age is not really a restriction for my applications of this product. So now I want to spend a little more time talking about what's become a large part of my practice. And I know you all have had a talk about the 10X procedure recently. When I first spoke to Ben about what I wanted to talk about is mostly about this and its applications to the elbow, the foot, the ankle, and the hip. And we sort of segued into let's approach it to the hip. So this has become a huge part of my practice. I've done over 200 of these for greater trochanteric pain syndrome. Had one this afternoon. And what this is based off of, I'll get into, but basically there's ultrasound studies that show that bursitis is really present in a minority of these patients is gluteal tendinopathy. So there was a small study in 2019. This is probably one of the only studies I found on this topic that found a 90% success rate with the 10X procedure. The pros of this, minimal downtime, a high success rate. If it fails, you can still do an arthroscopic procedure. The downside being the risk of failure. It doesn't address bursitis or IT band pathology. So first I want to talk about what I did my first 4 or 5 years in practice. This was an arthroscopic procedure. I'd put a cannula at the top, at the bottom of the greater troch. I'd split the IT band. I used X-ray during the procedure to make sure I'm in the right place. I'd clear out the bursa. I'd debride the gluteal tendon, and then I would inject platelet-rich plasma when I'm all done. This is what it looks like if you turn this 90 degrees. I'll show you the arthroscopic photos in a minute, but it's very clear to see where all the pathology is here. So this is an example of one that I've done. That first layer you're seeing is the split IT band. We split it vertically, so looking to the left is towards the patient's foot, looking towards the right is towards the patient's head. And you split the IT band to gain access to the next layer. And that next layer is the bursitis. And that looks like this wet tissue paper. It's just this thickened stuff that you can tell is snapping, it's inflamed, it's aggravated. And I use X-ray during this part of the procedure to make sure I go all the way to the top of the bursa, the bottom bursa, the front, the back, and get every bit of it. And then deep below, there's the glute medius tendon. We can tell it's the glute medius tendon because it's rising from posterior to anterior. The glute minimus comes from proximal to distal. And then that picture on the right is that partial thickness glute medius tear that everybody has with greater trochanteric pain syndrome. It's not a bare area, so it doesn't need to be repaired. So this is one where I would have removed I would have lengthened the IT band, cleared out the bursa, and then placed a needle in there so that when the wounds are all closed and the fluid's out, I would then inject platelet-rich plasma at the end. The problem with this procedure was the recovery. We'd have people minimize their activity for a week, minimize walking and standing for another 20 to 30 minutes for the next 4 weeks. And then up to 12 weeks, we'd have them really limiting their activity. I didn't use physical therapy much with this procedure because a lot of times the hips were so aggravated that the physical therapy in the earlier days would make it worse, unless there's a gluteal repair that's done concomitantly. And this is my problem with it. I only had about a 60, maybe 70% success rate, which is abysmal in orthopedic surgery. I hate doing operations unless I have a 90 to 95+% success rates. And what I noticed with this, it took me several years to identify it, was that people just weren't doing well. And there's not a lot of literature on this. But then when I started looking at some of the newer studies that were published in 2019, 2020, there were similar success rates. And I have no idea why it's so poor, but I hate the fact that patients of mine were giving up 3 months of their lives for recovery that 1/3 of the time or more they weren't getting. So what I've learned from this is that the older, the slower, the younger people, they improve within weeks. Older people, it takes a minimum of 12 weeks, sometimes longer, sometimes need more cortisone. And then those without much muscle tone, those that aren't able to really strengthen the tendon back up, really don't do well with this procedure. But where they have done well is 10X. This is a product where it's a needle. We place it under ultrasound guidance, and that needle does two things. Under the ultrasound, I repeatedly poke the area where the gluteal tendinopathy is, and it's very clear. It's a dark black signal of unhealthy tissue. And the first thing it does is it debrides the disorganized collagen tissue. And the second thing it does is it elicits a healing response. And the reason why this works is in tendinitis, collagen is no longer this nice clean sheet of tissue. It's disorganized fibers. It's a lot of haphazard array of tissue that then we're able to pick out piecemeal with the 10X probe. This is a picture of what it looks like when I'm doing it for the foot. The picture is me on the left, the right is not me. But basically, it shows clearly where the tendinopathy is. It's that black signal that's not so healthy. For everything except the hip, I do these under local anesthesia. And the hip, we use a little bit of light sedation because it's a very difficult area to numb up. But it's very easy to see under ultrasound where the problem is. And so I have patients actually tell me, or I'll palpate before the procedure in the preoperative area, find where most of the pain is, and then I'll place an ultrasound, look all over the hip, and 99% of the time, the tendinitis is right in that spot where they poked around and showed me where the pain is. So there's a high correlation between the symptoms and where they actually have the pathology here, fortunately. So 3 steps to the procedure. We do diagnostic ultrasound. I place a 10X needle under ultrasound, and then I perform the tenotomy. But I'm not actually cutting the entire tendon. I'm only picking out small pieces of it. It's only about a 10-minute process. Local anesthesia for the majorities, light sedation for the hip. I do these every Tuesday afternoon, usually 2, sometimes 3. And I did a tendon elbow this afternoon, and then a gluteal tendinopathy to follow. And they're great procedures. I have a great streamlined team that does these with me every week. In terms of the recovery, hips, we really only limit activity for the first week. Elbows, we brace for 4 weeks, and we have them begin lifting at 6 weeks. Foot and ankle, we do a boot for 4 weeks, we go running at 6 to 8 weeks. And a lot of this is just when I started doing a lot of these in 2018, 2019, I met with the guy who actually developed this product. It was before he had sold the company. He was still trying to make a name for it, and he actually met up with me and told me how things interfere with cortisone, how to load them with physical therapy, and what his experience with it was. And the interesting thing was the guy who developed it was a neurologist. So somebody who thought completely outside the box about how to address this issue has really been our biggest cure for a lot of these things. So my experience with 10X, I've done over 200 of these in the last 5 years. The majority of them have been for gluteal tendinopathy, and I've had an unbelievably high success rates. Hips, about 95%. I'm probably at about 140, 150 hips at this point. Elbows, 90%. Insertional Achilles tendonitis is the one that doesn't work as well. And then plantar fasciitis, I've had 100% success rates. And I've done for hamstring issues as well that we'll talk about as well. So what was interesting about 10X here was when I made that change around 2023, I had a couple patients. I'd done the arthroscopic procedure on that weren't doing well, 4 hips, and they were still seeing me and still frustrated. And I said, hold on, let's try doing 10X for this. So these are people who have already had the arthroscopic procedure. And all 4 of those actually went on to do great. And the great thing about this procedure is, unlike other parts of the body and the hip, people are telling me as soon as 48 hours after the procedure, their pain is better than it was before the procedure. Usually it's 10 to 14 days, but this is the one place where within 2 to 3 days, the pain is significantly better with really no downside to it. So the idea came from this was that what I learned after doing many years of orthopedic surgery training and extra training in orthopedic surgery fellowship was that for some reason none of my patients wanted surgery, even though it was all that I knew how to do. And a lot of it came from the fact that there's long recoveries. It's an unpredictable recovery. And what we define as success is not always success. The biggest place where I see this is with an ACL reconstruction. I do a lot of ACLs, and not everybody gets back to sports. But by definition, because their ACL hasn't retorn, that's considered a success in the orthopedic surgery literature. In the reality, it's not. If I don't get somebody back to their baseline activity or past that, to me, it's not meeting the expectation that the operation was intended to do. So the idea of adapting to the hip came from high success rates with tennis elbow, plantar fasciitis, and others. And my real thing behind this was that if greater trochanteric pain syndrome is really a tendon issue, let's treat the tendon. The pros, it's reproducible, it's a rapid recovery, it's covered by insurance, unlike platelet-rich plasma and a lot of other modalities, and I have not seen a single disadvantage yet. So next thing we're going to talk about is things intra-articularly within the hip. Number one being labral tears, which are very, very common, especially as we get older. Femoral acetabular impingement, there are 3 different types. There's the pincer deformity, where the overhang of the acetabulum, the much more common cam deformity, where you have this excessive bony growth around the femoral head neck junction, and then the combined modality. And then another newer entity is something called subspine impingement, which we see sometimes, not as common. This is where the anterior inferior iliac spine is protuberant, or it's really prominent, and it can actually rub up against the femoral head and create an internal impingement in that area. So subspine impingements and abnormal articulation between the AIIS and the femoral head junction. The difficulty with this is it's the same pattern as FAI and labral tears. It's anterior pain, it's worse with flexion, it's identified with CT or more commonly intraoperatively, because you can actually palpate with a probe how low-hanging that AIIS is. And then we treat at the time of hip arthroscopy. It's rarely something that occurs in isolation. So what I want to spend the next few minutes talking about is a new coin phrase in orthopedic surgery called modern hip arthroscopy. And this is because our techniques for hip arthroscopy have changed in the last 5 or 6 years drastically. Hip arthroscopy does not have a long history. A lot of the advent of it came around 2005 to 2010. When I was in residency, it was not taught in the beginning. It was so new. So that was even just around 2010, 2011. The people that taught me hip arthroscopy had to go off to various places throughout the world to learn how to do it. They weren't taught in their training. So I was really that first generation of orthopedic surgeons where hip arthroscopy was starting to be taught and instilled in our residencies by my 4th or 5th year of residency. So the way I liken this to patients when I explain to them is it's sort of like when you learn a foreign language. It's much easier to learn as a kid when you're learning lots of new techniques at the same time than going back and retraining as an adult, because everything about hip arthroscopy is different than the shoulder and the knee. The instrumentation is different. You use a 70-degree scope. You have much smaller moves into the hand. The hip is a much more different, complicated joints. And so the advances keep coming. And so there have been probably about 5 or 6 major advances in the last 5 years alone that have made us basically reevaluate outcomes in hip arthroscopy. All the literature on hip arthroscopy up to 2020 was based on older, more antiquated techniques. Now the studies are being redone with this modern hip arthroscopy protocols, and the outcomes are even better than they've been in the past. So this is just the first example. That table on the left is what I learned to do hip arthroscopy on. You had a huge post between the legs. You would pull a huge amount of traction on it, and then you'd swing the leg over, hear a pop, and then you get an x-ray and hopefully the hip joint would be open. And as you can imagine, that's a huge traumatic force on the hip. You're essentially almost dislocating it. Plus that huge post, placing pressure on the pudendal nerve, about a 10% risk of pudendal nerve injury. That force was transient, but this procedure, it hurt a lot that way. This table on the right, I started using around 2019, 2020. I was one of the first in the area to use it, and it's tractionless surgery. Basically, what it is patients are placed onto a table. Here they are in a Trendelenburg position, meaning their feet are higher than their head. Now we actually do it completely flat, and you put down a foam pad, and basically that pad helps to distract the joints. You just pull a little pressure through the legs, and the hips open up. When I do these procedures, I don't use paralytic agents with our anesthesiologists. A lot of orthopedic surgeons do. And then it makes it a little bit more of a dangerous procedure because they're paralyzed during it. They can have issues with their airway afterwards. Takes longer to wake up. I don't use paralytics. We basically just apply gentle traction across the hip without a post, and the hip joint opens adequately for arthroscopic access. So the biggest difference with this is patients are not waking up screaming in pain like they used to. And that's much easier to get their pain back down over the first 3 to 4 days and get them into physical therapy within that first 1 to 2 weeks. The second thing that changed is we use X-ray intraoperatively because the if you don't correct the cam deformity, these labral tears recur. And so the number one reason why somebody fails a hip arthroscopy is the surgeon missed the cam deformity. And what that means is when I was in training, we would look at an x-ray and say, it looks like a perfect circle. I think I got it. Maybe there's a little bit more there to get, but you take the hip through various angles and hope you got it all. About 5 years ago, I was among the first orthopedic surgeons in the region as well to start using something called hip check. What that means, if you look at the computer on the bottom, that's me with my surgical tech, and I'm looking at everything arthroscopically on that top TV, but the bottom is actually an iPad that's plugged into our x-ray machine. And it has a software put into it that measures the alpha angle that you can see on the right. And so what I'm doing is I'm making measurements before I do a camera section and then afterwards. And I'm taking the hip through flexion, extension, internal and external rotation. And so the two greatest benefits of this, number one, it makes sure my patients have their entire camera section taken down so they're not likely to fail the surgery. And number two, it's cut my operative time down significantly. Rather than having to look around the hip and figure out where this cam deformity is, it shows me exactly where it is intraoperatively. So routinely, I'm doing hip arthroscopies in an hour 15, hour 20. The average hip arthroscopy is roughly 2.5 to 3 hours. And before I was using this, just because I only do a few different procedures, I feel like my hands get that memory to them. I was doing this in about 2 hours, but it's actually knocked about 30 to 40 minutes off my operative time. And that's not to brag and say that I'm a faster, better surgeon, but it means that you have less time to disrupt tissues, less time to distract the hip, and it makes it a more efficient experience for everybody involved. The other thing that's changed, we used to leave the capsule. The hip is the only joint that has such a thick capsule that you actually have to cut a hole in the capsule in order to move your instruments in and out. So we used to leave that defect open. Then we would start to open it just in people who are ligamentously lax. Now there's a lot of literature that shows you need to close it in everybody, and that's having improved patient outcomes by doing this. And then the last thing is the PRP that I'm injecting at the time of the surgery. And then finally, labral reconstructions is not a procedure I do very often. I think it's overused right now. There's some thought in doing it in patients who have never had a hip surgery. I'm using it more in revisions. This is one of the first ones that I did. This is an Instagram post that I did about it where the patient basically had no labrum after their first hip surgery because the surgeon had debrided their labrum. We've known for many years the outcomes of labral debridement are not good, so I repair everything, and if it can't be repaired, I reconstruct it. So this is what a reconstruction looks like when we have new donor tissue to reconstruct that labrum in the same hip. So what hasn't changed is the high quality repair, fixing the labrum, the impingement, and then the post-operative therapy. In the posterior aspect of the hip, there's issue of femoral impingement, which is extremely rare, where the lesser trochanter can impinge the ischium, can even compress the sciatic nerve, and then proximal hamstring tendinopathy and tears. Issue of femoral impingement, like I mentioned, is very, very rare. It's buttock pain, groin pain with radicular pain down the back of the leg if the sciatic nerve is involved. And the risk factors include osteoarthritis, femoral deformities, prior surgery, and congenital abnormalities. I'm not sure I've ever seen one of these. In terms of proximal hamstring tendinopathy, I've done 2 10X for these. One of them was about 3 months ago. And this was a guy who had 30 years of pain. He even had an open surgery in the 1990s, PRP injections, tons of physical therapy. He was an avid cyclist and had issues. And he's doing great. He's says he has a little bit of pain just with changing position, but he no longer has that nagging pain when he sits for a prolonged amount of time. And then the other one was a guy in his 40s who's an avid cyclist. He had had 5 years of pain, and with a single 10x procedure, both these people have been cured. Now getting to the anterior aspect of the hip, there's iliopsoas tendonitis, and then we'll finish on the athletic hernia and pubalgia. So iliopsoas tendonitis can happen in both native and prosthetic hips. It's reproducible pain with a straight leg raise. A diagnostic corticosteroid injection can be helpful. In native hips, it's almost always improved with physical therapy and or these guided injections, but physical therapy 999 out of 1,000 times helps us fix these. Prosthetic hips, it's a lower success rate. A lot of times it's because there's just so much irritation there, the tendon's under constant tension, or something else that's causing an issue in that area. Sometimes it's even an overhanging acetabular component, although that's rare. So I've done a handful of these in prosthetic hips where the iliopsoas tendon is extremely painful after a hip replacement. And so it's amenable to an arthroscopic tenotomy. This is picture on the left shows you where I'm putting this wand to basically burn off the tendon. We're going over the front of the hip to the lesser trochanter. And then that picture in the middle is what it looks like with the iliopsoas attached to the lesser troch. And then the picture on the right is what it looks like when I've completely detached the iliopsoas tendon. What's interesting about this is there's really no significant loss of hip flexion. Bearing in mind, these are patients who have had arthroplasty, so they're not the highest demand to begin with, but it's almost an instantaneous pain relief in a lot of times just because of the resolution of tension in that area. And then finally, we'll finish with the athletic hernia and pubalgia. It's not a true hernia. It's a painful constellation of anterior hip, lower abdominal pain from the tendinopathy of the adductors, the rectus abdominis, and basically all these tendons that insert around the anterior aspect of the pelvis. It's best visualized on a pelvis MRI, not a hip MRI. A lot of times we see osteitis pubis and other issues with this. The other interesting thing about athletic hernias is that a lot of times we see them in conjunction with labral tears. And this is something that I'm sure you all can help me understand better than I can, as since your biomechanical understanding surpasses mine. But my understanding of that is that when you have a painful labrum, it causes your body to move differently, which can then overload the adductors and the pubic symphysis. So there has actually been there was a study published in the American Journal of Sports Medicine that showed it was a case series of patients with concomitant labral tears that were symptomatic and athletic hernias. And the athletic hernias all seem to resolve when you treat the underlying issue in those patients, which was the labral tear. So I thought that was interesting. It at least made some sense to me. The treatment for athletic hernias, physical therapy, more physical therapy, the more physical therapy, that fixes everybody for the most part. If that doesn't work, my go-to is PRP injection right into the aponeurosis or the area where there's significant tendinopathy. And then finally, surgical debridement and repair from our general surgery partners. Not a procedure I've ever seen done before, except on VuMedi, but something that does have significant data behind its use in the select patient population. So, conclusion here, the hip's a complex joint. There are multiple pain generators in every region. Choosing the right treatment requires comprehension of the relevant anatomy. The treatment options are constantly changing and improving our patients' outcomes. The things I've talked about tonight will probably be outdated in 5 years. If I'm still doing my job with keeping up with journals and talking to peers and going to meetings, my hope is that it will be different. Virtually everything about my practice has changed just in the last 5 years. The way I do ACLs, using mostly a quadriceps tendon autograft now, or using a lateral extraarticular tenodesis, doing acellular dermal allografts to basically reinforce these large rotator cuff tears that have abysmal healing rates. There's a lot of data out there. The idea is just we need to figure out what's going to be the most beneficial to our patients, and the hip is no different. And then finally, just some thoughts about when to escalate care. You all are my first, second, and third line of treatment in virtually every issue except for an ACL tear, an acute traumatic rotator cuff tear. Virtually everything else in my practice relies on physical therapy. What I want is the referrals in cases where you feel that the response is not what you expect it to be. That shoulder that should have gotten better after the first 6 or 8 sessions of physical therapy that's having no response, or the frozen shoulder that's not behaving, or if there's been no response to therapy. Or the other thing is if something just doesn't seem right, stress fractures, spondylolisthesis, a lot of issues even in the lower back that don't necessarily jump out but can be confused with other overlying etiologies in that area. And then finally, when there's any uncertainty in diagnosis, and this is one where I'm not afraid of getting an MRI, especially in that 17-year-old gymnast who's had 12 weeks of pain despite taking time off, and I'm more concerned about a pars defect than I am about a lumbar strain at that point. That is one case where I feel like an MRI is very helpful, even if it's not going to change our treatment a whole lot. But for almost every other condition, thank you for everything that you all do in helping my patients. And then the last thing I wanted to add, dry needling. It's something where I have routinely had great responses from my patients going to Jackson clinics. I'm a huge fan of dry needling. I've had it multiple times myself for issues, and it's amazing how people just do so well with Achilles tendonitis, plantar fasciitis, issues that are so much due to tightness. And I know there's conflicting literature in the physical therapy world about it, but my experience in talking to patients and talking to more and more people like yourselves is it's a powerful tool. So I'm glad it's something that we can continue to offer our patients. And then finally, here's my contact email, phone number, my Instagram info. Contact me any way you'd like to. I'd be happy to continue to work with you all. If you all have any questions about patients that might benefit from these services or just want to learn more about it, let me know. This is my practice here. There's 7 of us with all different branches of orthopedic surgery. The only commonality is Dr. Griffith and I are both sports trained, but he does shoulder replacements. I don't do shoulder replacements. I do hip arthroscopy. He does not. But otherwise, we have a fantastic team of nurse practitioners and physician assistants as well.
Amazing talk. Thank you. I think the amount of content you covered is maybe unprecedented in these calls. You like hit so many incredible updates for us. Quick question to sort of open the chat feature here is when we have someone on our team who wants to escalate care, do you want them to text you directly, email you? What works best for you there?
Just have them call my office. That's never a
Okay.
problem. We keep spots open for acute injuries just because a lot of our practice is the kids hurting themselves at lacrosse or on the playground over the weekend. So I hold spots in my schedule for basically same day appointments. So rarely do people have to wait more than 24 to 48 hours to either get into me or if I'm unavailable, someone else on my team. But honestly, just giving them our phone numbers the best information, the best way possible. But if it's something where you're concerned about diagnosis, you want to give me a little leadway information to help clue me in, I appreciate those texts as well, or email, whatever's easier.
Fantastic. Thank you. Any questions, AB or Phil or John, Kyle, anything from you guys on the amazing content he's covered this evening?
I do have a question, Dr. Goodwin, and this not one of your patients, but I do have a relatively young, like 38-year-old female who was recently diagnosed with a hip labral tear. And she had an interesting pain presentation. Like it seemed like it was referring mainly to her proximal hamstring. A diagnostic cortisone steroid injection kind of resolved her pain immediately. But now I'm like cautious with how much I should push her on that. So, when I think about that pain coming back and what to tell her to watch out for as that cortisone wears off, like what guidance would you give her to like start loading?
So at that point, when I've sent patients for cortisone injection, the idea is you get them back to full activity or it hasn't done its job. Generally what I tell people is after a cortisone shot, take it easy for 2 weeks, no hip flexion past 90 degrees, including squats, sit-ups, deadlifts. And then after about 2 weeks, start to push it a little bit, go into more aggressive walking, start doing body weight squats. But if they can't resume full activity 4 to 6 weeks after that shot or the pain comes back, the issue is not fixed. And then depending on the status of the cartilage, if it's a 58-year-old where the outcomes of hip arthroscopy are not nearly as good as a 38-year-old, that's one where I would even start thinking about PRP because they've already proven they benefit from an intra-articular injection. And a 58-year-old has very different demands than a 38-year-old.
Okay, thank you.
You're welcome.
All right, I have another small question, sir. It's based on a knee challenging case that I'm having right now. Like, first of all, it's so good to hear that I'm not the only one who is wasting too much time in looking at the proximal stuff to make sure that my life is going to be easier if I can rule the neck or the back first before I get to the hip or the shoulder. My question is, I have a kid. He's 9 years old with osteochondrosis dissecans right now, and like the presentation is like it's not making sense to me at all. So he says that he can like walk around with no pain, and then he goes to soccer 1 day a week now, which is less than what he was doing before, which was 5 days in a week, different games. But like he's having pain with terminal knee extension and with like just body weight or like 1 or 2 pounds on the leg. And it's like almost 2 months and it's not getting better.
Yeah, so OCD is a really interesting thing. The treatment guidelines for that follow a very easy to follow algorithm. And if it is a stable OCD, which it sounds like it is, we restrict activity for 6 weeks. And if the pain comes back, like it's localized to that femoral condyle, or they get effusions, it needs some amount of stimulation to heal it. So a
Okay.
procedure. If it sounds like if there's pain with extension, that probably means there's an effusion. If they can't straighten their leg out, and that's creating an issue. I don't think it necessarily be from a hamstring issue in that area. And that makes me think that no matter what you do, it might not be a successful case on your end because the OCD is not healed.
I got you. Okay. So that is like a referral for you directly.
At that point, I would, especially if they've rested for 2 months and still symptomatic. And even the unstable ones, they have a lower healing rate, but kids, especially 9-year-olds, almost always heal these. We don't typically repeat imaging because the imaging does not change within 6 to 12 months. But it's also easy to tell from an examination sometimes if that spot's symptomatic or not. So if there's an effusion or they're tender over where the OCD is, then you know that's the underlying issue.
Gotcha. Okay.
All right. Thank you so much for the talk. Want to respect your time late on a Tuesday night. Really, really appreciate everything. And as I said, recording is going out tomorrow morning to our entire squad. So you'll have 130 something eyes on it. Really appreciate everything. Everyone should have his contact info. And with your permission, Dr. Goodwin, I'll add that into the email as well when I copy you, just so that people have that direct contact info. But thanks again and appreciate your time, and we'll be in touch very soon, I'm sure.
Sounds good. Thanks, guys.
Thanks
Thank you.
again.